My name is Don Thomas. I'm a rheumatologist who specializes in taking care of patients with lupus, Sjogren's disease, and other autoimmune diseases. And I was very fortunate to be able to attend the American College of Rheumatology's yearly annual meeting that was held right here in the Washington, D.C. area. And I chose 3 highlights from the meeting. First will be about CAR T-cell therapy. Number 2 will be about 2 exciting drugs who passed their primary endpoints in phase 3 clinical trials. And then lastly, I'd like to talk about the lupus nephritis guidelines, which are just fantastic in my opinion. So first off, I'd like to say that the meeting this year, I want to call it the year of CAR T-cell therapy. CAR T stands for chimeric antigen receptor T-cell therapy, and it really looks like a revolutionary way to possibly treat lupus. What they do is, in patients with severe lupus, they take out a type of white blood cell called the T cells, and then they program those T cells to be able to kill B cells. Now, the importance of this is, all of you who are watching this who have systemic lupus, you have autoantibodies. Autoantibodies are antibodies that attack your own body, like anti-nuclear antibody, anti-double-stranded DNA antibody, and so on. Well, the cells that make those antibodies are called B cells. And so just think about it. If we could get rid of those bad B cells, couldn't that be good for lupus? And that's exactly what this therapy does. They put these T cells back into the person's body. Those T cells kill all the bad B cells. It also kills good B cells, but within 90 days, the immune system is reprogrammed and healthy, normal B cells come back and not the bad B cells. Using this therapy, over 43 patients with severe systemic lupus have been treated. Almost all of them went into complete drug-free remission. Think of that, in complete remission on no medications, not even steroids. A couple of patients have been in remission now for 5 years. Another patient's been in remission for over 3 years. And so this is really exciting. And there are very few side effects. There were some mild infections, but that was it. Well, during this meeting, we had over 24 abstracts and research findings and talks about CAR T-cell therapy. There are several CAR T-cell therapies that are now in clinical phase 1 and phase 2 clinical trials, and they have FDA fast tracking. So I really think that this is going to be a new chapter in the treatment of systemic lupus. So keep your eyes and ears open for the next few years to see how these clinical trials pan out. Number 2, there are 2 drugs that have passed their phase 3 clinical trial results. Now, the way that the FDA sets up research studies for possible new medications, there's phase 1, phase 2, and phase 3. Phase 3 is the most important. It has the largest number of patients. It looks at the effectiveness of the drugs as well as the safety of the drugs. Many drugs pass the phase 1 and phase 2 trials, but very few pass the phase 3. In the past 10 years, since 2010, there's only been 3 drugs that have been FDA approved with passing their phase 3 clinical trials. That's Benlysta, Saphnelo, and Lupkynis for lupus nephritis. Well, one of the drugs that has achieved its primary endpoints in a phase 3 clinical trial is called obinutuzumab. It also goes by the name Gazyva. It's already commercially available to treat other diseases. It's related to Rituxan. So any of you who have been on Rituxan, it's kind of related to that in that it kills a type of B cell called CD20 B cells. Well, Gazyva or obinutuzumab, it showed that it increased the complete response rates, or you can think of it as remission for lupus nephritis patients. It was able to cut down on their need for steroids, and there was less proteinuria. So right now, it's also in phase 3, a second phase 3 clinical trial. So we're really looking forward to see what those results will show. The second drug is a completely new type of drug, and it's really important that we continue to look for drugs that can work in different ways for systemic lupus. The immune system of lupus abnormalities is just ridiculously complex. There's hundreds of different players, and in each lupus patient, different parts of the immune system can be abnormal. The two drugs that we have FDA approved right now, the biologics for systemic lupus, are Benlysta and Saphnelo, and they work in two completely different ways. Benlysta decreases B cell activity, while Saphnelo decreases the effects of something called interferon type 1. Some patients do amazing on Benlysta and don't respond at all to Saphnelo, and then other patients are doing amazing on Saphnelo and not responding to Benlysta. But unfortunately, we have patients who don't respond to either one, so we need new medicines. Or there's this biologic medicine called dapirolizumab. This is a tough one to say. Dapirolizumab. Dapirolizumab, it works in a completely different way, but it decreases how T cells tell B cells to become more active. Remember, I told you that B cells are the cells that make those bad autoantibodies. Well, one way that T cells tell B cells to be more active is that there's a CD40 ligand or a connector on the T cell that connects to a CD40 receptor on the B cell. And when they connect, it tells that B cell to become more active. Well, the way that this medicine works, dapirolizumab, is that it binds to the T cell CD40 ligand to keep it from telling that B cell to become more active. So this is a medicine or biologics that's given intravenously every 4 weeks, and it passed its primary endpoint in the phase 3 clinical trial, which is just phenomenal. And here are just some of the results that I wrote down. They looked at something called the BICLA. The BICLA stands for the British Isles Composite Lupus assessment score, and it looks at 92 different manifestations of systemic lupus, and patients had to have significant improvement from, if they had severe disease activity in an organ group, it had to go down to at least moderate. If they had moderate, it had to go down to at least mild, and every single problem that the patient had to improve in those, and every part that was either moderately or severely active. By looking at that measurement, the patients who received the study drug, 50% of them met this BICLA. The patients who received other therapies like hydroxychloroquine, mycophenolate, methotrexate, azathioprine, the BICLA score was reached by 35%. That meant that 43% more patients who took the study drug had a great response to the medication. So that's a really good response, Brianna. And right now, they're getting ready to start another phase 3 clinical trial. And if that one also passes, we're looking at the possibility of 2 more FDA-approved drugs, which would be really, really exciting.
Wow.
This drug also had a couple of other important things. It had an acceptable, it was able to decrease flare rates by 50%. It also had an acceptable safety profile. When they looked at side effects in this study, 83% of the patients who took the study drug had side effects, but 75% of them in the other group had side effects. Now, this doesn't mean that this drug causes side effects in 83% of people, by the way. What it means is that this study drug was added on top of other drugs like steroids and mycophenolate, and then those patients did report some side effects like stomach upset, for example, or rash, or elevated liver enzymes. But it doesn't mean that the study drug did it. It could have been the other drugs that the patient was on, or it could have been due to the lupus. The FDA is not in charge of defining if a side effect was due to the drug or due to the lupus itself. Most importantly, there was no statistically significant difference between placebo and the study drug. The other interesting thing is they looked at severe side effects. The percentage of patients on the study drug plus other therapies, 10% of them had a severe side effect that was ascribed to any of those medications. Now, you might think that was a lot, but in the placebo group, it was 15%. 10% on the study drug, 15% on the placebo. Now, how can that be possible? Placebo doesn't cause more side effects. You know, a fake intravenous fluid doesn't cause side effects. But an interesting thing is that there was a lot less steroids that had to be used in the patients on the study drug. Steroids are the #1 cause of side effects and infections in our patients. So me as a rheumatologist, my mind is churning and I'm thinking, well, maybe it might have to do with the people having not having to take as much steroids compared to the patients who are on placebo. That's just my thought process, and it'll be interesting to see what the next phase 3 clinical trial shows. But it's really exciting that we're coming into this new chapter in the treatment of lupus patients with possibility of CAR T-cell therapy and 2 possible new drugs for systemic lupus. Then the third and final thing I wanted to touch upon are lupus nephritis guidelines. First off, what are the importance of guidelines? You would think that all rheumatologists read all the medical literature and know everything there is about every disease, but you know, that's impossible. Every month, there's hundreds of different research articles that come out. You know, there's over 100 different types of arthritis, over 100 different causes. It's impossible as a rheumatologist to know those. I spend all my time reading all the lupus literature. It's impossible for me to read all the rheumatoid arthritis, psoriatic arthritis literature. So I rely upon those experts to review the medical literature, then come up with guidelines that tell me as a lupus doctor how to treat my rheumatoid arthritis patients and psoriatic arthritis patients better. And that's what these guidelines for lupus nephritis are. They're going to tell your rheumatologist the best way to take care of lupus nephritis. Lupus nephritis is where lupus attacks the kidneys, or inflammation of the kidneys. It's the #1 cause of patients not doing well or dying from their lupus. So it's an incredibly important thing to learn how to treat. What percentage of patients develop lupus nephritis? 4 out of every 10. So 2 out of every 5 systemic lupus patients will develop this problem, and that's why it's such an important thing for all lupus patients to know about. Some important numbers to know for lupus nephritis that will help you understand why these guidelines are so important. When you look at those patients with lupus nephritis, so again, that's 40% of all systemic lupus patients, 10 years after the diagnosis, 1 out of every 5 will be in complete kidney failure. 1 out of every 5 will require dialysis or a kidney transplant.
Wow.
That's how important it is. But those numbers are driven by one important thing, and that's by the percentage of patients who go into a complete renal response or complete remission. And this is incredibly important. So often I have a patient who's sitting in front of me who quote unquote feels good, and I tell them their lupus is not under as good a control as we want, and I really want to escalate their therapy better, and I'll sometimes get resistance from them because why should I, you know, escalate my therapy if I'm feeling so good? And this is just one reason. There was a study that came out in 2008, Dr. Chen et al. It was a nationwide study that included places like Rush, the Cleveland Clinic, and they combined their patients who had severe lupus nephritis, a type called class 4 lupus nephritis. They treated them and then they followed them for 10 years. And they asked the question, what's the difference between our patients who go into complete remission versus those who have a partial remission? Think about that. They have a great response, but they're not 100% in remission. We'll call it partial remission. And those who just don't have a good response. Well, the ones who don't have a good response, they just did horrible. So I'm not even going to mention those. Let's just look at complete remission and partial remission. The lupus nephritis patients who went into a complete remission at the 10-year mark, and here's the numbers, I wrote them down. The percentage of patients who did not have to go on dialysis, the ones who were in complete remission, 5% did not have to go on dialysis. I'm sorry, if only 5%, 5% went on dialysis, the other 95% did not go on dialysis. But those who went into a partial remission, 55% ended up on dialysis. 55% needed a kidney transplant, while only 5% of those who went into complete remission needed a kidney transplant. That's a huge difference. But that's not where it stops. Lupus nephritis is severe. The medicines we have to use are intense. High-dose steroids, for example, increase the risk of infections and even death from infections. So what percentage of the patients died at 10 years? Those who went into a complete renal response or complete remission, 8% of them died. 8 out of every 100 patients. But those who had a partial remission, a great response but not complete remission, 57% of them died. 8% versus 57%. Again, it's a huge difference. Our goal is complete remission. It's not a partial remission. And so that's why when your rheumatologist wants to get you into a really good remission response, please pay close attention to them. There's very good reasons on why we want to do that. So the reason I bring all this up is that when we look at research studies for lupus nephritis, we want to look at that complete remission or complete renal response. How good are the patients going into that? So first, let's look at the older therapies. And by the way, these older therapies are not that old. I was in rheumatology fellowship in the early 1990s. The medicine that we used in the early 1990s was high-dose steroids and cyclophosphamide. Guess what the drugs of choice were just 5 years ago? High-dose steroids and cyclophosphamide. The third one was mycophenolate, but the studies on mycophenolate showed something called non-inferiority. It didn't prove that it was, all that much greater better than cyclophosphamide, but it was non-superior to cyclophosphamide. So we use either mycophenolate plus high-dose steroids or cyclophosphamide plus high-dose steroids, but we've been doing that for 2 decades. Over the past 20 years, there's been multiple clinical trials for lupus nephritis drugs. Only 2 of them passed the primary endpoint, and that was Benlysta and Lupkynis, both of which are now FDA approved to treat lupus nephritis. But what all of these studies had in common was the following. Those patients who were treated with the older therapies, and again, these older therapies are only 5 years old, the ones on mycophenolate or cyclophosphamide, only 25% to 30% of patients on average had a complete renal response. Think of that. We were failing the vast majority of patients. Those patients, that 65 to 70% of patients, those are the ones that were at very high risk of ending up in complete kidney failure and ending up on dialysis. So what did the research studies show for Benlysta and for Lupkynis, which are now the 2 FDA-approved drugs to treat lupus nephritis? And those patients who received Benlysta plus either mycophenolate or cyclophosphamide, they had a 70% greater odds of going into a complete renal response. 70% greater odds. The patients who were on Lupkynis plus mycophenolate, Lupkynis is also called voclosporin, they were twice as likely to go into a complete renal response, or what you can consider as complete remission. So lupus experts like myself, who treat a lot of lupus nephritis and systemic lupus, it was a no-brainer to us that we were going to use these medicines in our patients right when we diagnosed them with lupus nephritis. But unfortunately, the word didn't get out to all the other rheumatologists throughout the world, and there was a lot of controversy, or there was a lot of opinions on whether they should be using these medicines or not. Well, the American College of Rheumatology got together some of the best lupus experts in the United States. They dove through all of the lupus nephritis research, and they came up with these very important guidelines. So these are guidelines that are very easily accessible and learnable by all rheumatologists, including those who don't specialize in lupus. And one of the most important things that they recommend in these, Brianna, is that all patients with severe lupus nephritis should immediately be treated with what we call triple immunosuppressive therapy. And that's steroids plus mycophenolate or cyclophosphamide, which are the older drugs, but also adding on top of that either Benlysta or a calcineurin inhibitor like lupinase. With doing that, we're going to greatly increase the chances of remission in so many patients.
Wow.
Another important thing is that steroids, like I said, are the worst medicines for our patients. They're absolutely necessary because they're life-saving immediately, but they're guaranteed to cause side effects in the long run. The less we use in the long run, the better. And the studies, remember I mentioned the Benlysta and the lupinase studies, they showed us that we can get away with much less doses of steroids. And so another recommendation is to use less steroids. And so they do specifically state what those doses are. And so no longer will patients hopefully be treated with such high doses as they were just even a few years ago, which is great. Another thing about these guidelines is that they also tell rheumatologists how to take care of children with systemic lupus and lupus nephritis. You know, even though we talk about lupus primarily affecting women of childbearing years, and that's because of the extra estrogen, which causes immune system activity, we diagnose patients with systemic lupus from just a few years old up into their 80s. And the problem is that our children have the most severe lupus. The vast majority of them even have severe lupus nephritis. And so having guidelines to tell doctors how to treat those children with lupus nephritis is incredibly important. And so that was included in the guidelines. And then the last thing I like to touch upon before we come to the Q&A is they also delve into how we should treat the older patient with lupus. Remember I said that even 80-year-olds can develop lupus. So those patients with lupus nephritis who are above the age of 50, it gives us some great recommendations on how to treat those patients in a safer manner. So that's just 3 things that came out of the ACR meeting that I thought were key highlights or important points. There was much more than that, of course, but I just thought I would share these with you as key takeaway points for the Lupus LA community. And if you have any questions for me, Brianna, I'm more than happy to answer any.
We definitely do. First of all, thank you so much for sharing the updates with our community. It's super helpful. Like you mentioned, not every practitioner has the time to stay on top of things like this, and making the effort to go and to hear the information and then share it with us is really helpful. So thank you so much for doing that, Dr. Thomas. Okay, where do we want to start? Let's see. I think we have some general questions for you and then questions specifically about what you spoke about. So I think I'll talk first about the ones that were coming in around what you mentioned. So the first one here is, will my doctor know about the new lupus nephritis guidelines? Do I have to tell them?
Oh, that's always a good question. Hopefully your rheumatologist knows about them, because they really have commercialized them or announced them. About every rheumatologist who's a member of the American College of Rheumatology has received emails announcing these new lupus nephritis guidelines. So hopefully you don't. But, you know, they are available online. It doesn't hurt to print them out and, you know, just hand them to your rheumatologist and just tell them it's a courtesy you're doing for them.
That's great advice. Thank you. The next one here is, it's about, they're asking about the Gazyva, the one that starts with an O and ends with the mab.
Benituzumab.
Yeah, I'm trying to interpret the attempt at spelling this. Will other patients be able to take Gazyva, or only lupus nephritis patients? Will this help other lupus patients?
Yeah, that's a good question. It's probably just going to be FDA approved for lupus nephritis, because the FDA will only approve a medicine for how the clinical trial was structured. So at first, that's what's most likely going to happen. But then, like with other drugs, like rituximab, for example, Rituxan, which Gazyva is very closely related to, we don't use it just for lupus nephritis. We use it for other severe manifestations of lupus, like even brain lupus, for example. So I can easily foresee it being used for other purposes in the future. And by the way, Gazyva is currently available. I've actually already treated 3 patients with severe systemic
Really?
lupus with Gazyva because it's FDA approved for other disorders. So even though it's not FDA approved yet for lupus nephritis, it is out there and available, particularly for patients who have failed multiple other medications.
Interesting. Okay. Um, the next question is the triple therapy that you were discussing, that like 3-prong approach to getting things under control quickly. Is that how long do you do that for, or do you wait for certain markers to change? So is it related to the time frame or that someone's labs?
That is a great point. The lupus nephritis guidelines, they actually go into great detail to answer that particular question. And even though I said a triple immunosuppressant therapy, I actually like to think of it as quadruple immunomodulating therapy, because the other recommendation is that every single lupus nephritis patient should also be on hydroxychloroquine. The
Oh,
reason
okay.
the reason for that is that taking hydroxychloroquine, which is such an incredibly safe medicine compared to the immunosuppressants, it increases the remission rates threefold. So just think about that. The other medicines already increased the remission rates by up to twofold, and then here's hydroxychloroquine that can increase it up to even threefold, even more on top of that. So I like to think of it as quadruple therapy. Well, they do recommend that once we find a successful regimen, figuring out which 4 medicines you end up using, that patient should be treated for at least 3 to 5 years. And then most of us feel very strongly that at the 3-year mark, we should rebiopsy patients. Even if they look like they're in remission, we should rebiopsy them to see if they're truly in remission, to see if we can start to taper off the strongest immunosuppressant drug at that particular point. Now, the question about what markers should be followed and how often, it's recommended that we follow the proteinuria.
Okay.
And this is such an important point, by the way. Lupus patients oftentimes get tired of coming to see their rheumatologist. We're asking you to come in every 3 months to check your blood work and your urine sample. The reason for that is that when lupus affects the kidneys, and remember, it's 40% of patients, people
Yeah.
have no symptoms whatsoever when they have early lupus nephritis. That's when we want to catch it, is in the earliest stages. And the way that we do that is by looking at the amount of protein in the urine. Well, that's also what we look at to see how well someone responds to therapy. And we want to monitor their urine protein, usually monthly at first, and then at some point we go to every 3 months. But we have certain targets that we want to get to with each of those. For example, at the 3-month mark, we want to see a 25% reduction in proteinuria. At the 6-month mark, we want to see at least a 50% reduction. And then at the 1-year mark, we want to see the urine protein to creatinine ratio less than 700. If we see those things happen, that particular patient has a much reduced risk of ending up going into dialysis or kidney failure. And that's why those numbers are so important. Now, as we're watching those numbers, if we don't see them hit exactly those targets, then we want to adjust their therapy. Like, let's say I have a patient on Benlysta as the 3rd drug. I might want to change that to Lupkynis instead, or change it to tacrolimus instead. Or I might want to add that medicine to the regimen. That's another option, is to use Benlysta plus Lupkynis plus mycophenolate and hydroxychloroquine. But all of these are spelled out in the lupus nephritis guidelines so that even non-lupus experts can learn all this complicated stuff to take better care of our patients.
Yeah. Well, that's good, because it sounds like a very custom cocktail experience as you move
Yes.
forward. Thank you so much for explaining all that. That's so interesting. The next question that we have is about the mention of steroids and the issues with them. So actually, let me back up. Let's start here because we have a question that's kind of prefaces that. It says, are there any medications that were discussed as being problematic or no longer recommended for treating lupus in light of new drugs and therapies coming out at ACR?
100% yes.
Really?
Steroids,
Oh,
prednisone.
steroids.
The P in prednisone stands for poison. That's what Dr. Michelle Petrie likes to say at Johns Hopkins, and I 100% agree with her.
Oh my
And
goodness.
it always makes me worried when a patient wants to stay on low doses of prednisone, but is afraid of taking Benlysta or afraid of taking
Yeah.
methotrexate. Those medicines are so much safer and more effective than steroids. The problem with prednisone, even with doses less than 5 milligrams a day, is that it increases the risk for organ damage in the body. Things such as cataracts, diabetes, high blood pressure, strokes, heart attacks. Even doses below 5 milligrams increase the risk of infections, and people need to understand this. While the vast majority of the immunosuppressants don't increase infections in most of our patients, but prednisone, steroids, absolutely does. Of course,
Mm.
in my clinic, by doing all the stuff I just talked about, most of my patients are not on any steroids, or those who are on very low doses, and we want that to happen in every single lupus clinic or every rheumatologist office in the entire world, if they follow the better medicines that are currently out there. Right now, it's not a steroid-free state, but hopefully we'll gradually get to that point over time.
Yeah, I think that makes sense. New things you haven't tried before, it can be scary. And if you've already had a positive experience or been able to handle prednisone, I can definitely understand, some of the hesitation or trepidation around that. So thank you for explaining a lot of the science and some of the studies that kind of help people kind of come around to understanding why this is a big and positive shift with the new medications.
Sure. And Brianna, another reason for that, by the way, is you give someone prednisone, and a lot of times they feel up on top of the world, and
Yeah.
they can clean their house and do all their chores,
Tons
and
of
they feel
spring
amazing.
cleaning. Yeah.
But you put them on hydroxychloroquine, it's like, okay, when is this going to start working? It's okay. It's a
Mhm.
month into it. I don't feel anything. These are slower working medicines in the long run. And so that's another obstacle to get over. Here's this medicine that makes them feel good right away, while these other medicines are slower to work. But we got to just have to educate patients on they need to give them time.
Definitely. That's a huge distinction. I'm so glad you said that because I think just hearing that and knowing that that's normal can kind of help, assuage some of that sensation that it's not as effective or not as, safe as taking a steroid if it's worked before. So super helpful. Actually, we have a question about hormones and steroids. And the question is about the estrogen that you mentioned and how sometimes that can be problematic, obviously, with activating the immune system. And, so many women that have lupus. Do you find that when you're treating patients when they are on prednisone or steroids that it actually like increases the testosterone or bounces out some of that element with the hormones, or not really?
Well, we haven't really studied that in great detail, or not enough to really see that that makes a big difference at all.
Okay.
But estrogen is certainly an important drug for women to sometimes take. For example, low dose estrogen contraceptive pills are generally safe in our patients as long as they don't have antiphospholipid antibodies. Those patients should not take them. And then after menopause, of course, some women can have just horrible hot flashes that can be devastating for quality of life. And we do have hormone replacement therapy available, but those hormone replacement therapies do have higher doses of estrogen and can potentially cause mild to moderate lupus flares. And so in those patients, we try to stay away from estrogen, but if we have to, you're looking at quality of life versus a mild flare of lupus. That's something we sometimes have to talk to the patient about. But as far as what steroids do with the hormones, we don't really have that. We don't
Studied
know enough
well.
about that to really have that change the way that we think.
Okay, that makes sense. This one is a little bit more general versus ACR, but why does lupus suddenly manifest in some people if they didn't feel sick as a kid? Was it bound to manifest, or was it environmental triggers that triggered it? Is it a difference in our DNA that causes someone to get lupus this quickly?
Sure. And so that's a great question. Right now, first off, I hate the studies that start off with the phrase lupus is a disease of unknown cause. You'll see that all over the place. If Lupus LA has that somewhere on your website, please get rid of that. I hate it. Lupus is a genetic disease. It's what we call a polygenetic disease. There's over 180 genes that have been identified so far that increase the risk of developing lupus. The more you inherit, the more likely it is for you to develop lupus over time. Also, some genes are much more likely to cause lupus than other genes are. For example, there are some genes that all you have to do is inherit one of them, and you have a 75% chance of getting lupus. Now, those genes, that's what causes some young children, like 2-year-olds and 3-year-olds, to develop severe lupus, and they do get it like abruptly, and they get it very severely when it comes on. So, but looking at older patients, older children, adolescents, adults, some patients will get it abruptly all at once, while some patients they'll get just like a few symptoms over time. And you'll oftentimes hear that it takes an average of 4 to 6 years to get a diagnosis of lupus after the onset of symptoms. And that's the type of patient that's talking about. So let's talk about what happens with the genes and how lupus develops. It goes through different stages. So you're born with the genetics that can cause the disease, but the vast majority of people never get the disease. But those people who have those genes, they'll oftentimes have an aunt with thyroid disease, another aunt with rheumatoid arthritis, an uncle who has Sjogren's disease, and so forth, because all of these diseases are caused by the same genes, but that person may never develop any of those genes. But it takes triggers to turn those genes on and cause the immune system to become overactive. And those triggers include things like ultraviolet light exposure, smoking, even secondhand smoke, low vitamin D levels, improper food intake. For example, there were some nice studies this past year that showed people who eat a diet high in ultra processed foods have an increased risk of getting systemic lupus. Pollution is another one that's also been shown. Stress, a lack of sleep. They're just amazing how many triggers can turn those genes on and cause them for the person to develop lupus. It's most likely a multiple hit thing. Like, just think about it. Every day you're out in the sun and like you get some ultraviolet light, that's tens of thousands of times you're going to get that throughout your lifetime, or you get repeatedly exposed to cigarette smoke and so forth. So it probably takes just multiple hits with the trigger until finally the disease becomes active. Some people, it unfortunately becomes severe all at once, but most people it's kind of a slowly, gradually increasing thing where they might have some fatigue at first, some achiness that comes and goes, then maybe their fingers might start to turn white or blue, and with cold exposure, or what we call Raynaud's phenomenon, and so forth. Or let's look at that person who goes on I had a 16-year-old I saw just a few years ago, and she went on a trip with her parents to the Caribbean, had a lot of sun exposure, then became very, very sick all at once because of that UV light exposure on the beach. So it does vary a lot from person to person, but it is a genetic disease.
That's so fascinating. We do hear from patients, I went on a trip, I was in the sun a lot, and then that was what kind of pushed what I was already experiencing over the edge. That's so interesting. Are we okay on time, Dr. Thomas? Can we do a couple more?
Yep, I'm here. Okay. I'm ready. It's a Friday night. I'm gonna watch Netflix when I get done, so I still have some time.
Okay, great.
Eat some popcorn.
So the next question, it's a little bit lengthy, so I'll try to just summarize it. It's basically asking, how do you handle that idea that you were talking about earlier, where patients really struggle to want to take on more or increase medications or layer in additional therapies and deal with potentially increased side effects of their medication in pursuit of that full remission to give themselves that great long-term position in terms of the disease activity when they're experiencing side effects. So if you're, encouraging somebody to reach that full remission and really deepen the therapies, but they're experiencing, certain side effects. How do you sort of approach that conversation with somebody who's like conscientious about that increasing and looking at the remission?
Sure. So I like to approach this in two different directions. First, that patient who is doing well, feels good, but I want to
Well
get her off
enough.
the steroids, and I want to add something to get her off the steroids. I have to teach that person that the side effects are not definite side effects, they're potential side effects. And the
Mm-hmm.
vast majority of people will never get any of those side effects. And that's such an important thing to teach. But the prednisone, I guarantee 100% is going to cause side effects. Now, the person who's having side effects, this is incredibly important. Uh, I'm very active on social media. For example, I'm on Reddit, the subreddit, Reddit, the lupus subreddit a lot. And
Sure.
oftentimes I'll see questions put up like methotrexate is causing me to feel horrible. I'm getting this horrible rash and my stomach hurts. Tell your rheumatologist, we don't want our patients to have any side effects at all. I want you to feel like you're not taking a medicine whatsoever. For example, if I put someone on methotrexate and you get stomach upset, I don't want you to have stomach upset. I want you to tell me right away because I can make a difference. I would have you stop the methotrexate and then re-add it at a lower dose, gradually go up on the dose. And if you get any stomach upset at all, I want you to back down to the dose that you tolerated. We absolutely can deal with side effects by just changing how we deal with the medication, or if it's already a low dose, stop it and try something different. So please don't put up with side effects. Talk with your doctor on how to get rid of those side effects and use something that's not going to make you feel bad.
That's great advice. I think a lot of people assume that it's just part of the situation and that they have to be on certain therapies, suffering, or maybe don't speak up and say something. So that's super helpful advice. Speaking
Yeah,
of
please
methotrexate,
do. Oh, and by the way, Brianna,
yeah,
most doctors are using patient portals these days. A lot of my patients are not signed up. I don't know why, but sign
yeah,
up for the patient portal. It's such an easy thing to do, to send a message to your doctor saying, doc, I started that methotrexate and now once I'm having some sores in my mouth and I don't like that, what should I do? And then your doctor can just type back real quickly, exactly what to do. So take advantage of that patient portal for things
yeah.
like this.
That's a great point. Yeah, a lot of people do not use that, and it can be a much longer process to have communication outside of appointments if that's the case. And
Yeah,
that can be
don't
really
don't wait
discouraging.
don't wait for your 3-month appointment. Don't do that.
Yeah, great advice. So speaking of methotrexate, we had somebody ask if you have ever used cyclosporin in a lupus patient. If that's something,
Absolutely.
and what are those situations?
We used to use cyclosporin a lot. Cyclosporin is in a group of drugs called calcineurin inhibitors. And when I was talking about the lupus nephritis guidelines, I mentioned that term. I said we could either add Benlysta on top of the steroids and mycophenolate, or a calcineurin inhibitor like voclosporin or tacrolimus. So calcineurin inhibitors are a type of immunosuppressant that calm down how T cells work. Those are the cells, again, that make the B cells more active. We can think of the calcineurin inhibitors as there's three different generations. There's the oldest generation, or the first generation, called cyclosporin, the second generation called tacrolimus, and now the third generation called voclosporin or lupus. Each of them are safer than the predecessor. So we used to use cyclosporin quite a bit, but then the safer tacrolimus came about, where we could get away with lower doses and with much less side effects than cyclosporin. And so I haven't used cyclosporin in a long time. I used to use it quite a bit, but tacrolimus is safer, so I use that now instead. But now we have voclosporin or lupus for lupus nephritis, and that's probably even safer than tacrolimus in a lot of people. So things are getting better over time. I've used it, but I haven't had to use it in quite a while now because of the newer medicines.
Okay, that's very interesting. The next question they asked about that is between methotrexate and cyclosporin, do you find that one of them has less side effects than another?
Yeah,
typically?
100% methotrexate. No, I'm sorry, methotrexate is safer overall than cyclosporin.
Okay.
Cyclosporin, boy, we have to monitor the kidney function and the blood pressure like every 2 weeks when we put the person on the medication. That's how
Wow.
closely we have to watch it for side effects. But the vast majority of people on methotrexate don't get any side effects.
Okay. And then the last question here on the medications, I don't know that this is something you might be able to answer, but it asks about cyclosporin versus steroids. Is there research that shows that these impact the microbiome? Which of these might impact the microbiome less? I don't know if that's something that you can even conjecture around, but have you ever seen any like research about that?
Sure. So, for those who don't know what the microbiome is, micro refers to microorganisms like yeast and viruses and bacteria. Then the biome is the entire world of those microbial species. Inside of our bodies and on our bodies, we literally have trillions of microbial organisms living on us and inside of us. In fact, there's more of them than there are the cells in our body. So you can think of us as being more microbiome than we are even human beings. The importance of this is that those bacteria and viruses and fungus and so forth, they actually interact with the immune system. It can cause the immune system to become overactive. The largest immune system organ in the entire body is actually the intestines. And so if you think of that important immune system, and it has the most white blood cells, by the way, of the immune system, and just think of all the bacteria and food that we eat interacting with that immune system. And studies clearly show that people with severe active systemic lupus or lupus nephritis, they have an abnormal microbiome compared to patients who are doing very well with their lupus or people who are very healthy. So having a good or normal microbiome is incredibly important. Now, the big question is one of the big questions is how do the medicines interfere with the microbiome?
Yeah.
We still have way too much to learn about that. So we really don't know the answer, but they are doing the studies to look at it. For example, when you look at the really sick person with systemic lupus who has an abnormal microbiome, the
Hmm.
question is, well, is that abnormal microbiome, is it causing the lupus to become more active?
Sure.
Or could it be abnormal because of the high doses of
Hmm.
steroids being used? And those are the kind of questions that we need to answer. But it does look very interesting that food probably plays a role. For example, there's a really interesting study where they took mice with lupus, and in half of the lupus mice, they fed them a diet that was high in prebiotics, a specific type of prebiotic called resistant starches, and that would be like things like a cold oatmeal, like overnight oats, for example. And what they showed is that the mice who ate the resistant starches in their diet or had a very high diet of it, they had a much better microbiome, and their immune systems were not as overactive with their lupus. Their lupus was actually under better control than the mice that ate a regular diet. And so
Wow.
we can probably improve the microbiome with diet. And that's why I'm a big proponent of an anti-inflammatory diet that includes things such as omega-3 fatty acids like walnuts and white fish, but also prebiotics like oatmeal, for example, and probiotics like yogurt with live cultures.
Wow. That was so helpful. Thank you.
Hope
Um,
it's not too much information.
no, it was incredibly interesting. Super interesting. The last question we'll ask you from Penelope is, can you comment on the use of colchicine for SLE? Is that something that you use in your practice?
Yes, absolutely, and good to hear from you, Penelope. I remember you asking this question before. So colchicine is an anti-inflammatory medication. It's as old as probably Greek medicine. It comes from a crocus called the autumn crocus, and it's been used for a long time in medicine. But
Wow.
we use it in very tiny amounts, especially for a disease called gout, because it
Hmm.
decreases the inflammatory gout attacks that can be just horrible in people. But it can also be very helpful in the pleurisy of lupus. So I do absolutely have some patients with pleurisy. that if they get a pleuritic attack or a pleurisy attack, I'll have them take 2 tablets of colchicine immediately and then another tablet an hour later. And oftentimes that can be incredibly helpful for their pleurisy. Some
Wow.
patients end up getting recurrent pleurisy, and so I'll have them on daily colchicine to help decrease those attacks from happening. So it can be very helpful in particular patients.
Wow, that's so interesting. Just last follow up on that, for when you're doing that, is it usually that the patient does it like in a short few day course, or is it something that they would notice results with quickly usually? If colchicine is going to have an effect on like pericarditis or pleurisy or anything like that, would it kind of you would see the results rather quickly, or is that something you have to wait a few weeks to kind of see how colchicine supports it?
Yeah, great question. Because most of our medicines, we tell people you got to wait a few weeks or wait a few months. A good thing about
Hmm.
colchicine is that it's fast. You'll know within 24 to 48 hours if it's going to help resolve or decrease your pleurisy.
Hmm.
And if it does help out like that, and if someone has recurrent pleurisy, then that's the person that'll put it on. Have them take it every day.
Okay. Wow, thank you. It is always awesome to speak with you, Dr. Thomas. Thank you so much for all of your thoughts today. I will, if anyone who missed it or is coming in at the tail end, we'll have the recording on YouTube and Facebook tonight. So you'll be able to rewatch it and check on anything that you missed. And as always, we'll put the link in the comments to join the community so that you get early notice on when we're going to have these live sessions so that we can get your questions answered. Thank you so much for your time.
You're welcome. And just remember, everybody, knowledge is power. And please join Lupus LA. Have people donate money, because the more we can give to research, the better. So I hope everybody has a good weekend. Bye-bye.
Thank you.